For short-term use in the operating theatre or the intensive care unit, the disposable, single-lumen thermosensitive tube with a low-pressure, high-volume cuff design is suitable. The cuff allows a sufficient seal to prevent gas leak, with minimal pressure being applied to the soft inner mucosa of the trachea when inflated correctly. The cuff also reduces the risk of aspiration of gastric contents into the lungs. The adjustable flange model has similar characteristics to a standard single-lumen tube, with one difference. The flange can be adjusted to vary the depth of the tube. This may be required for patients who have deep-set tracheas caused by inflammation, obesity, or anatomical changes in the spine. The tube opening protrudes further than a standard tube, preventing partial or total occlusion by the patient's chin. The pilot balloon reflects the cuff inflation status, not the cuff pressure being exerted onto the mucosa. The one-way valve facilitates cuff inflation and deflation when the valve is depressed with a syringe tip. A single-lumen tube is similar to all endotracheal tubes. Secretions can build up on the inside of the tube, reducing the internal diameter and increasing the work of breathing. Good care should prevent this. However, total occlusion of the tube can still occur. Therefore, it's best practice to change these tubes every 7 to 14 days. To reduce the risk of secretion accumulation, use of a two-piece system with an inner cannula and outer tube can be utilised. The inner cannula can be removed and replaced without disturbing the outer tube. This is extremely useful in an emergency where occlusion is suspected, possibly avoiding the need for a complete tube change. There are two types of modern two-piece system. They can be the soft, thermosensitive or rigid type of PVC tube. Selection is dependent on the needs and wishes of the patient, hospital policy or medical preference. The original two-piece system was of the now outmoded silver Negus tubes, which have mostly been phased out due to cost, lack of comfort and disposability. Not all manufacturers' two-piece systems allow for a permanent 15mm connection when the inner cannula is removed for cleaning. By not having a 15mm termination, there is an inability to connect to ventilation or humidification devices. This could cause complications in an emergency situation. Patients with a permanent tracheostomy may use tubes without a 15mm connection, as the tube appears less obtrusive for them. Mini tracheostomy tubes are cuffless, small tubes used for either emergency procedures in life-threatening airway obstruction or for patients who have sputum retention. An uncuffed tube is selected when a cuff is no longer required for ventilation purposes or when there is no longer a suspected risk of aspiration of gastrointestinal contents. Providing the patient does not require further ventilation, this is the most appropriate tube as it reduces cuff-related complications. Fenestrated tubes allow for a direct flow of expired air to the larynx to aid vocalization. They may have single or multiple fenestrations and are useful in weaning and communication. Universal precautions must be used when handling the tracheostomy tube. Adhering to infection control policy, with good hand washing, drying and the wearing of gloves, aprons and eye protection should be routinely practiced by all practitioners. The patient should be informed of any intended procedures, however simple, and where possible their consent and cooperation obtained.